Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective. Welcome to Behavioral Health Today. I'm your host, Peter Fenger. My guest today is Dr. Barry K. Herman. Barry is a Stanford-trained, board-certified psychiatrist in adult and child and adolescent psychiatry. With over 25 years of experience spanning managed care, pharmaceuticals, and digital health. He's the medical officer at Mentavi Health, leading innovations in telehealth and digital therapeutics, including the highly accurate Mentavi Diagnostic Evaluation. A prolific researcher and author over 100 scientific articles and abstracts, Dr. Herman is also a past president of the American Association for Psychiatric Administration and Leadership, and the recipient of several American Psychiatric Association awards. Throughout his career, he's been dedicated to improving the lives of patients and their families through evidence-based mental health solutions. In our episode today, we'll explore Dr. Herman's journey in psychiatry and digital health, the development and clinical validation of the Mentavi Diagnostic Evaluation, how it improves accuracy and reduces bias in adult ADHD diagnosis, and what this innovation means for the future of online mental health care. Barry, it's so nice to have you on the show today. Welcome.
Thanks so much, Peter. Great to meet you and happy to be here.
You know, Barry, I've had a lot of fun researching you and your background and your work with Mentavi Health. I know that your path began as a child psychiatrist and eventually led to where you're at now as Chief Medical Officer at Mentavi Health. Share with our listeners a little bit more about your journey from child psychiatrist to your role now as Chief Medical Officer at Mentavi Health.
Sure. Well, I would have to say that my career path has been non-traditional in many ways. It's certainly been non-linear. As you said, I began my career as a child and adolescent psychiatrist. I trained in child psychiatry at Stanford and then embarked on a career in clinical practice for about 15 years. And I saw children and their families in my practice and treated a lot of kids. And at some point, I decided I wanted to be doing more than I was doing. And I felt like there has to be a way that I can help more people than the traditional patient-doctor encounter one by one in a clinical practice. And that led to my decision to actually take some time off, go back to school. I got a master's degree in medical management at Tulane. And at that point, I became very interested in the whole idea of population health, meaning being able to be involved in decisions that impact many people at once. And the first step in that process was I started working in the insurance industry in managed care. I did that for a couple of years, and it was a good education for me about population health, but it wasn't really a good fit for me in terms of the way in which managed care operates in the United States. Mm-hmm. So I transitioned out of managed care and began what I call my real encore career, which began in 2001 when I started working in the pharmaceutical industry. And that began a 20-year career in pharma that was characterized by increasing level of responsibility in terms of the roles that I assumed. My last job in pharma was as chief medical officer for a company called Tris Pharma, and we had a portfolio of branded ADHD medicines. I would say for the last 8 to 10 years in pharma, and my role in pharma was really both in what is called medical affairs, which is really how a company disseminates and educates the scientific community and the public about its clinical data for its products. and also
Mhm.
in clinical development, which is the actual process of trying to bring a new drug to the market. And I had leadership roles from the even from the start in both of those activities in pharma.
Yeah.
I worked at
Yeah.
several companies. I would say the last 8 to 10 years in pharma were very much focused on ADHD and related disorders. So as
Okay.
a child psychiatrist, where really the bread and butter of my practice was treating neurodevelopmental disorders, including ADHD, to my 20 years in pharma, the last years of which were very much focused on ADHD and the medicines that treat ADHD. And then I transitioned out of pharma about 5 years ago into the digital space. I first began working for a small digital therapeutic startup company. I'm still involved with that company. But about
Yeah.
2.5 years ago, the opportunity came up to work with Mentavi Health, where I am now
Nice.
as chief medical
Nice.
officer. And this Mentavi is a national telehealth platform that originally in its history, focused on diagnosing and then diagnosing and treating ADHD, but now has expanded to diagnose and treat ADHD and co occurring or related disorders that are commonly seen with ADHD. And so we do both diagnosis and treatment. Telehealth has been really a great advent for the
Hmm.
field because it's made diagnosis and treatment much more accessible for folks. And so this has brought me much closer or almost full circle to where I began my career in really
Right.
focusing on treating patients, which is why I became a doctor, right? So this has been really very gratifying to be able to have an opportunity, especially to make diagnosis and treatment much more affordable to folks out there, wherever they are.
Right. Yeah, I love this journey that you've taken really from helping individuals and then really trying to take a role to where you can, apply your skills to a greater population within public health. And even just your experience within pharma and really having a really clinical understanding of those medications and now really applying it to the other side, which is just treating, it's assessing and the assessment tools. And I think that the ADHD smart assessment is actually very neat. It's interesting to hear about your career transition from one-on-one child psychiatry to more of a public health view and your role with Mentavi Health. But I'm curious, what sort of led to the creation of Mentavi Diagnostic Evaluation?
Okay. Well, the history of our company at Mentavi was the company was initially named ADHD Online.
Mm.
There still is an ADHD Online. It's like a subsidiary of the parent company, Mentavi Health. And it was founded by two folks who saw an opportunity, recognized an unmet medical need. This was several years before I was involved with the company. And those founders, one of whom was a primary care physician, really recognized the fact that ADHD was underdiagnosed and undertreated. And from a timing standpoint, the company began in 2018. It focused almost exclusively on offering online diagnostic assessment for ADHD. They did very well because there was such an unmet need in that area and they recognized it and people came. The timing from the standpoint of the beginning of the company couldn't have been more fortuitous because within a year and a half, COVID hit. And COVID created a huge tailwind for online telehealth and virtual diagnosis and treatment
Mhm.
that really pushed and accelerate the popularity of telehealth. And along with
Right.
that tailwind, the company expanded from just diagnosis to both diagnosis and treatment. and they created a platform for being able to both diagnose and treat ADHD. I came on board 2.5 years ago. And so one of the things that we realized was that it's very hard to just treat ADHD in a vacuum. About 80% of people with ADHD have at least one other psychiatric diagnosis. And the most common co occurring conditions with ADHD are anxiety and depression. And we felt like we should be paying much more attention to those disorders and training and educating and bringing on board providers who can feel comfortable and competent in treating not just ADHD, but ADHD and co-occurring conditions. I would characterize what we do from a treatment standpoint is we've created this kind of virtual ambulatory primary care clinic where we treat both ADHD and the most common conditions, mild to moderate in severity, which you would typically see in an outpatient primary care practice. We know that at least 50% of treatment of mental health conditions is taking place in the primary care setting. And we were looking
Right.
for primary care docs who were interested, passionate, and experienced in treating mental health conditions. So we've kind of expanded the umbrella of the services and expanded really the mission of the brand, if you will, being
Right.
Mentavi Health. The diagnostic evaluation, which is what used to be called the SMART assessment,
Okay.
was developed early on, but has undergone significant number of improvements and different iterations over time. The most recent iteration, which is, I think, the fifth version of the diagnostic evaluation now that happened after I came on board and we started working on that, was the one that we decided that we wanted to validate. And I can say more about that later, but telehealth had become increasingly popular. In fact,
Yes.
a recent Center for Disease Control and Prevention report showed that of adults with ADHD, 46% of them were using telehealth services. That's almost 50% of people out there with ADHD are using telehealth. And ironically, nobody had ever actually studied whether diagnosing and treating ADHD via telehealth was valid and reliable.
Right.
And especially when it came to diagnosis, there was a perception that it was very easy to get a diagnosis of ADHD online, that it was an excuse for being able to prescribe psychostimulant medications. So there were some companies that in fact were bad actors out there
Mhm.
and were not doing a very good job, a responsible job of diagnosing ADHD properly, and were way too quick to start prescribing medications.
Yes.
That was not the kind of way that we wanted to do business. We wanted to set the gold standard for the way that we diagnose and treat ADHD. And the first step in that process was being able to demonstrate the validity of our diagnostic evaluation in diagnosing ADHD in adults.
The landscape that you have described, the boom of telehealth, thanks to events like COVID, although telehealth was very evident before that,
Yeah.
not only does it paint this landscape of efficacious delivery of services, but also being able to serve more. Again, leaning back into your desire for public health, right? That there's alignment there. Talking a little bit about just the current state of ADHD clinical evaluation. Talk to me a little bit about what the standard in-person assessment looks like compared to your Mentavi diagnosis evaluation. And can you explain what the standard in-person assessment looks like and where could it fall short?
Right. Well, interestingly enough, ADHD really has no biomarkers at all to definitively diagnose it. So there's not like a blood test. There's not like a neuroimaging study. There's not really a genetic test. They're not even really diagnostic scales or even psychometric tests that can definitively diagnose ADHD. This current standard of care for diagnosing ADHD is a clinical interview performed by a licensed professional who hopefully has experience and expertise in diagnosing ADHD. And ADHD is diagnosed based on the current diagnostic criteria that are outlined in the DSM-5 Diagnostic and Statistical Manual of Mental Disorders, which is kind of known as the Bible of mental disorders that's published by the American Psychiatric Association. And the 5 means that's currently in its 5th edition. And it basically lays out the criteria for diagnosing all of the current mental health conditions out there. And the diagnostic interview ideally is focusing on those criteria in terms of how those are addressed with a patient in an office or face-to-face or even a virtual face-to-face setting.
Right.
Some clinical interviews are completely unstructured. They're just based on a clinical interview, just a history and a review of current symptoms that are going on and trying to map or match those symptoms against the criteria that are outlined in the DSM. Some clinical interviews are a little more structured. So some clinicians may use rating scales that are validated to be able to focus on specific symptoms that a patient is experiencing. They can combine the results of those scales with the questions that they're asking in the clinical interview to be able to arrive at a diagnosis. Some clinical interviews are even more structured. There are some fairly structured interviews that a clinician can go through to be very complete and try to match the diagnostic criteria to the diagnosis. But currently that is the standard of care. Now, to add to the sort of fuzziness, if you will, around diagnosing ADHD is the fact that in the United States, at least when it comes to adults, in the United States, there are no formal treatment guidelines for diagnosing and treating adult ADHD. Now, that's being addressed as we speak by an organization called the American Professional Society for ADHD and Related Disorders, or APSARD. And they've been working on developing treatment guidelines for adult ADHD now for a couple of years. And the expectation is that they're getting very close now to publishing those guidelines. But right now, there are none. There are guidelines in other countries like Canada and Europe, but there are none in the US. So that's made it even more challenging from the standpoint of standardization. And to actually bring that point to the fore, there's been research done on diagnosing ADHD in a clinical setting. The agreement between clinicians on diagnosis is not great, to be honest. In fact, there can be as much variation as 40 to 50% in difference of opinion about a diagnosis in a clinical interview. And yet, that is the current standard of care. And remember, diagnoses are being made by a whole range of folks out there, from highly trained specialists like psychiatrists and child psychiatrists, to mental health nurse practitioners, to physician assistants, to social workers, to psychologists, to counselors, and other physicians who are functioning as primary care physicians, like family physicians and general medicine physicians, and even some internists. So there are a lot of folks out there that are making these diagnoses. And one of the reasons for that is that there's a severe workforce shortage in psychiatry right now. Not everybody can have access to a mental health specialist. 60% of counties in the United States don't have a single psychiatrist. And that shortage keeps getting larger and larger. We can't close the gap. We can't train enough psychiatrists fast enough to fill that gap. So
Right.
other professionals, some of whom are mental health professionals, some of whom are not mental health professionals, are out there diagnosing and treating ADHD and other mental health conditions.
Right.
It makes it a real challenge.
It sounds real challenging. You're explaining that there are many different types of professions, all with varying degrees of their own assessment and no standardization to really kind of guide those diagnoses. But a tool like yours comes along. And as you had mentioned before, you guys have done research around it in order to build or show off the efficacy. I know from the first time we talked about your diagnostic evaluation, you spoke highly about the false positive rates. So, first off, what does your research show about the accuracy compared to traditional face to face clinical interview? And then talk to me a little bit about the difference in false positive rates.
Right. So, as I said, we really wanted to put our money where our mouth was, so to speak, in terms
Yes.
of demonstrating that what we were doing from a standpoint of asynchronous diagnosis. And asynchronous simply means that a patient can take this assessment without having to talk to a mental health professional. They can do it totally online and at their own time, anytime, at their own pace, 24/7, and they don't have to interact with another human being in order to receive a diagnosis. We felt very confident that what we were doing, what we had developed, was truly evidence based. But the only way to be able to do that would be to compare our diagnostic evaluation to the current standard of care, which is a clinical
Yes.
interview. And that's exactly what we did. We designed a clinical study called a real world observational study because it tried to mimic what goes on out there in the real world in diagnosing ADHD in adults. And we wanted to compare that with our diagnostic evaluation. And we conducted that study starting about a year and a half ago. The study was completed at the end of 2024. I'm very pleased to say that the outcome of that study demonstrated the validity and reliability of what we were doing, meaning it matched up very closely to the current standard of care, the clinical interview. And that was exactly what we did. We had over 300 subjects in the study who had both a clinical interview with a mental health professional, in this case, a doctoral level clinical psychologist. So someone who had a lot of experience and expertise in diagnosing ADHD. And we matched that against the same folks who took our online diagnostic evaluation. But what we
Yes.
saw, what the results showed or demonstrated, were that there was about an 80% level of agreement, which is very, very good.
Yes.
But more compelling was that we ran all kinds of different statistical analyses on the study. One of those statistics is called positive predictive value, which is really showing kind of the strength of the accuracy of what we were doing. And that was at the level of 95%. And to your point, and what was most compelling and I think important in many ways was that our diagnostic evaluation had a false positive rate of only 12% compared to almost 50% for the clinical interview. Also, at the same time, our diagnostic evaluation actually was much more conservative than the clinical interview in diagnosing ADHD in adults, meaning we were more likely to defer making a diagnosis than the clinicians who were doing the clinical interview were, meaning that when we weren't certain about a diagnosis, we didn't make a diagnosis of ADHD, we typically would defer that diagnosis and say further evaluation is required. And what that meant is our diagnostic evaluation is much more conservative in diagnosing ADHD than the current standard of care, which is a clinical interview, meaning we're not likely to overdiagnose ADHD. In fact, we're not overdiagnosing ADHD, meaning it's much less likely that patients are going to get prescribed psychostimulant medications because they're not receiving a diagnosis of ADHD with our diagnostic assessment until they've had a further evaluation. And that's exactly the kind of outcome that you would hope for in a study like this, particularly in addressing the concern about the ease in getting a diagnosis online of ADHD.
Yes.
So in fact, our diagnostic evaluation might be not too conservative, but it's definitely conservative when it comes to making the diagnosis. So we're very pleased with the outcome of the study. We actually had some formidable co-authors of the study working with us on that.
Mhm.
3 of them are arguably among the world's leading experts on ADHD. And so to have their participation and essentially their imprimatur on the results of the study was really gratifying for us. And we presented the data from the study for the first time at the ADHD World Congress in Prague, Czech Republic, in May of this year. At the same time, we had submitted the data from our study as a manuscript to a peer-reviewed journal, and we were fortunate to get that accepted very early after submission. And so that article was published in September in the Journal of Clinical Psychiatry. And since then, the data have been presented at another conference, soon to be presented at the APSARD, the organization I told you about, have an annual meeting. That's in January of this year, next month, and I'll be presenting the data from the study at that meeting.
Wow.
We're thrilled. We're thrilled with the outcome. It's the first time, to our knowledge, that anyone has ever demonstrated an online asynchronous evaluation is just as accurate as a clinical interview. And it really creates a scientific base to be able to say that what we're doing has validity.
Yes.
It's been a very gratifying year for us at the company to be able to do this. And we feel great about it. We think it advances the field for both diagnosing ADHD in adults, which is still very much a kind of underserved, underrepresented area. But even more importantly, to kind of push the field forward for telehealth as a real valid way of being able to diagnose people out there.
We'll be right back after a word from our sponsor. This episode is brought to you by Jane, a practice management software and EMR built to support you in the day-to-day work of running your business. If you're a health or wellness practitioner, you already know. The care you provide starts well before your patient arrives and extends far beyond the treatment room. Jane is here to support every part of that experience. With online booking, your clients can book at a time that works for them. And with features like waitlist notifications, they'll even be able to grab last-minute openings when they pop up. It's an easy way to keep your schedule full while giving your clients the care they need. During your appointment, Jane's AI-powered documentation feature can help you thoughtfully take notes so you can stay present with the person in front of you. And after appointment, you can end your time together on a healing note, not a transactional one, by charging the card on file and rebooking before they head out the door. To learn more about how Jane can support you and your clients, head to jane.app/demo. And if you're ready to get started with Jane, you can use our code TRIAD1MO for a 1-month grace period on your new account. When your work is about people, Jane supports the process.
Absolutely, absolutely. And what an accomplishment, not only to be able to show off your research, but also share that there can be a lot to gain from a standardization, which again, you're already predicting this to sort of ripple out for other ADHD diagnoses. So, yes, what an accomplishment. Congratulations on that.
Thanks so much.
I want to park on something that you talked about. So you talked a little bit about the validity of asynchronous assessment. I want to ask you, what advantages does answering on your own time have compared to, say, like a live interview?
There's been a fair amount of work done on the reliability of in-person diagnosis, especially when it comes to ADHD in adults. And there are what we call lots of implicit biases that are embedded in a face-to-face clinical interview. And we think that a lot of those inherent biases or implicit biases get wrung out by using a more structured asynchronous assessment. And the reason for that is multifactorial. I mean, first of all, our diagnostic evaluation is composed of quite a number of validated rating scales for a number of different mental health conditions, including ADHD. But it also contains numerous free text questions that are aligned with the DSM-5 criteria. Our diagnostic evaluation is dynamically modeled, meaning it's a machine learning enabled process whereby at each patient journey through the evaluation is going to be different because every question that they answer informs the next question that's asked.
Yeah.
So everybody's journey is going to be different because nobody's going to have exactly the same symptoms or have the same answers to every question. It's possible that somebody could actually answer as many as 600 questions, but because of the dynamic modeling that's embedded within it, nobody's going to answer 600 questions because
Sure.
certain lines of questioning are going to be cut off based on their responses. But it's modeled in a way that at the same time applies the same questions in the way that they're asked to every patient. So each question is asked in the same way to a patient because it's done online. You're basically just answering questions online. You can do it at your own pace. You can stop and come back to it. You can make multiple visits to the assessment. And I think that's good for some folks who may either get tired or distracted or just need a break, or they might get triggered by some questions and get emotionally distressed about some of the areas that they're asked about. And so it might be helpful for them to be able to take a break. But being able to do it on your own time, I think really has an advantage. It certainly reduces the influence of appearance, race, gender, the personality of a person, or their communication style, all of which in a face-to-face interview can introduce bias for sure.
Yes.
It really weighs symptoms and impairments in functioning in a very quantitative way rather than kind of based on impression, which is often the case in a face-to-face interview. And it really provides consistency across providers. So I should explain a little bit more about that. We don't have a machine making a diagnosis. I don't want people to get the wrong idea. Patients take the diagnostic evaluation, take it at their own time. They answer a number of questions, but those questions are then reviewed by a doctoral level clinical psychologist, a real human being who is looking at the questions, using their expertise and their judgment to be able to arrive at a diagnostic impression and to be able to produce a report. They even have the opportunity to reach out directly to a patient in some cases where they may need some clarification
Mm,
on the
that's
information
important.
that that they receive. Yeah, it is important. And
Yeah, that is
so
important.
there, every diagnosis that we're making at Mentavi Health is being made by a person, by a real person,
Mm,
an expert in diagnosing ADHD. So we think it's the perfect balance
yes.
between enabled technology and the human expertise that's necessary, really, to inform these kinds of decisions.
Yes. Yeah. It sounds just like that, right? You're delivering it in an online setting that gives access to anybody. You've created an environment where you can get better and more accurate results. And there's a human element on top of that where you have a degree of efficacy. So, yeah, I can imagine that the people that are coming through are not only getting accurate advice, but the program itself is being done in a way to ensure accuracy.
The other thing we've done is we've decoupled diagnosis from treatment, meaning
Mhm.
patients can get a diagnostic evaluation on our platform and there's no obligation to do anything beyond that. Once they
Yes.
get their diagnostic report,
Mm.
that report is portable. They can take it wherever they want. They can take it to an outside provider who can take a look at it, provide them treatment. Now that provider can have confidence that the diagnostic evaluation has been validated. And so they're less likely to object to receiving an online diagnostic report, knowing that there's now a scientific evidence base to support it. But patients can use it for any other purpose. For example, some patients will use that diagnostic evaluation to be able to seek an accommodation, either at school or in the work setting, or they can choose to go on and get treated on our platform. And currently, about 35 to 40% of patients who get diagnosed by our diagnostic evaluation will go on and get treated by one of our treatment providers in our
Sure.
network.
That seems like the best path, right? Being able to offer the diagnosis by itself, but give people an option if that's something that they wish to do. I want to sort of park on something you talked about because you mentioned your demographics and you described it as about the age of 35 and predominantly female. So I want to ask you, what do you think is driving this surge in adult women seeking evaluation?
It is very interesting, isn't it? And I think it totally reflects what's going on out there in the real world, which is the
Yes.
fact that research has consistently demonstrated that women and girls are much less likely to be identified with ADHD. They're
Mhm.
certainly diagnosed later in life. They're much more likely to receive alternative diagnoses such as anxiety or depression. And there are multiple factors that have contributed to that over the years. But I think it's really interesting to us that our website and the services that we're providing attract that population out there.
Yeah.
And women, we know, are underdiagnosed in the real world, that when they are diagnosed, it's much later than it should be, 5 to 10 years later in many cases, or even longer than that when it was clear they had ADHD as kids and just they were overlooked. So we're seeing this population that comes to our website and they're finally able to get a an assessment that really brings some of those implicit biases out of the
Yes.
equation. And interestingly, we've looked at our own data now. We've done, I think, about 110,000 diagnostic evaluations. Interestingly, we get about 200,000 visitors each month to our website, which I think reflects the fact that there are so many people out there that are looking for help, that they know that, or have a sense that something just isn't right and they're trying to get some answers out there. We've done our own data. We've shown that women and men are diagnosed about equally in terms of percentage. So we feel like that's a signal anyway that perhaps getting an asynchronous diagnosis like the one that we offer really does wring some of those implicit biases that occur in a face-to-face encounter.
Yes. Yeah, yeah. And then again, all of this sort of extends into your desire to address public health, right? Giving people access to a reliable assessment can be the real difference between somebody actually getting diagnosed and then those sort of living in that shadow.
That's exactly why I'm so passionate about what we're doing now, because of this workforce shortage and this lack of access to diagnosis and treatment for so many people out there. And there's a variety of reasons why people don't have access. Could be as simple as geography,
Yep.
but there are a lot of people that are estranged from the healthcare system for a number of different
Yeah.
reasons. And we wanted to create an opportunity to improve that access and affordability for people. So our diagnostic evaluation, first of all, you take it, and in 5 days or less, you have a full diagnostic report.
Yes.
Um,
Wow.
and
Phenomenal.
usually it's really 1 or 2 days, usually. And it costs $189. And yeah, $189 is $189 for some people. And for many people, it's expensive. It's out of pocket, but we remind people that they can, if they have a flexible spending account, they can use that to pay for it. Many of the people who take our diagnostic evaluation will submit that to their insurance company, and we'll provide them with
Mm.
a super bill to be able to do that. And many of them do get reimbursement from their insurance company. But if you compare that to what the alternative is for some of those folks in terms of trying to be able to get seen by anybody, sometimes
Yes.
the waiting lists are unreal. 6 months, a year is not
Right.
unheard of to try to get in to see someone. And I can tell you right now, to get a diagnostic evaluation out there is a lot more expensive than $189. The
Yes.
whole idea for us was, let's get these people that really don't have the access. Let's get it to them wherever they are, and get it to them at a cost that is affordable for many people.
Yeah. I can imagine those that are looking for assessment and some help, being able to get addressed quickly within a few days helps keep people in momentum. I know, again, just looking for help myself in other areas, the waiting period can be very discouraging.
Yes.
So
Yeah.
having a tool that can be immediate and access that can be immediate can be the real difference of somebody actually following through with that diagnosis.
Yeah. Think about a kid starting college, young adult who's starting college, may or may not have been diagnosed in the past, but now the demands are going to be much greater. There's going to be less structure. They're in a new situation, which is stressful. And that's where
Right.
you're more likely to see those symptoms coming out and affecting the way you're functioning. And just imagine them having to wait 3 or 4 months to be able to get in and get a diagnosis so that they can get accommodations and treatment. That semester is over. It's done.
Yes.
By the time that
Yep.
happens, we can
Right.
we can get them a diagnosis in less than a week, like I said, and that can make the difference between success and failure, for example, in an academic situation like that.
For our last question, I really want to kind of cast my rod into the future. I know you mentioned beyond ADHD, Mentavi is expanding into other areas like anxiety and depression. What can you tell me about maybe like some of the next steps for Mentavi and its future development in other mental health conditions?
Well, in terms of validation, that's a good question. We have thought about the idea of going ahead and validating our assessment for the more commonly occurring conditions that usually accompany ADHD, like depression, like anxiety. There's been some work that's been done already in that area. We may do it. We're not counting it out. More importantly, though, is we're really trying to expand the scope of what we provide to patients. We want them to feel confident that when we're assessing them, we're not just ADHD centric. We're not just focusing on ADHD, but we're looking at all those common conditions that usually occur with ADHD. And we want to be able to provide, if they want us to, we want to be able to provide treatment for those conditions. So not only expanding beyond ADHD, although we have been doing that for a while, we really have not been making ourselves that visible around that. But that's going to be changing moving forward. But in addition, we're expanding the range of clinical services that we're offering. So we're expanding our services in therapy and in coaching. Coaching has become huge now, as you're aware, in ADHD. And we feel like it's responsible to be able to offer one-stop shopping, if you will, to be able to offer a comprehensive treatment program for what we're treating. And so we're expanding our services in both therapy and coaching for folks. Currently, we can diagnose ADHD in all 50 states. We're currently treating in over 40 states. We're about to expand treatment to all 50 states because we're going to be treating things beyond ADHD routinely. And then coaching we offer in all 50 states and in therapy in quite a number of states, and we'll be expanding those services as well. So there are some other service lines that we're developing right now that make a lot of sense and will be a good fit for what we're currently doing. And I would say stay tuned for more news about those. But we're really excited about the future for Mentavi, and we're certainly excited about the role that telehealth plays in filling an important gap out there. You know, one of the solutions to the access problem is technology. And you said it, telehealth has been around for decades. It really wasn't until COVID that momentum really developed around telehealth as a way to be able to address access. I really truly believe that telehealth is here to stay. I think there's going to be much more science and evidence around the validity of telehealth for both diagnosis and treatment. Yes. You know, I'm happy right now and pleased and gratified to be able to be part of that effort.
Yeah, I would agree. And just with the time that I've spent here, I can really hear your passion around it. We started today's conversation around your journey from child psychiatry into more of the public health sector and now into your role as chief medical officer at Mentavi. I've really enjoyed our talk today, and the tool that you guys are delivering, not only does it sound like it is accurate and efficacious, but it also sounds like it's giving folks a lot of hope and an opportunity with access to, get these assessments themselves. So you're empowering a lot of folks to be able to take that step so they can take control over their mental health.
I couldn't have said it any better, Peter, really. And it's been a pleasure talking with you.
Yeah, likewise. But before we go, share with our listeners where they can learn more about Mentavi Health and where they could go to take the diagnostic evaluation.
www.mentavi.com. And you can even reach me through the website.
Awesome. Well, I'm hoping that our listeners will be able to take their chance and see it themselves. But for today, Barry, thank you very much for your time. It's been a pleasure having you on the show today.
Thanks so much. It's been a pleasure too.
I want to thank you, our listeners, for taking the time to join me. You can follow us on our social media at Instagram, TikTok, LinkedIn, YouTube, and more at Behavioral Health Today. If you like our show, give us 5 stars and leave us a review. And as always, the resources for this episode and an archive of all of our other episodes can be found on our webpage at triadhq.com/BHT. And we look forward to having you back with us next time on Behavioral Health Today. We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.